CTG monitor was commercialized by Hewlett-Packard back in 1968. And you'll probably know that working in 3 different parts of the world. Edward Hahn on the left, working in the United States, working basically with fetal ECG or scalp electrode signals. And then Caldero Basco there in the center, working in Uruguay, who's working with the implant contraction. But the man who put it all together in the first commercial monitor, developed a prototype, and then worked with HP, as they were at the time, was Hamacher, working in Germany. And when it started, right from the start, the 3 groups proposed 3 different ways of interpreting and classifying the CTG. So, disagreement really right from the start. But it didn't actually get any better, because in the 1970s and 1980s, there were 21 different CTG classifications evaluated, which were reviewed by Larry Gibo in 1985. So that some of them were connected to people's names, others to the name of the center where they were working. 21 different classifications. And then the largest or the most influential societies also came into play. American College was first, using the guidelines in 1979, and then several updates. FIGO, the International Federation of Gynecology and Obstetrics, which incorporates all the scientific societies at the country level. So it's I think it's 135 different societies. Came up with the first classification in 1987, and then with the update in 2015. And the RCOG and NICE are actually quite latecomers to this process. They only started having guidelines in 2001. As far as I understand, before it was basically FIGO 1987. And before we started the revision of the FIGO guidelines, or around the same time actually, we looked at which guidelines were available in Western Europe. It's a bit more difficult to get data from Eastern Europe because not all of it was in English. There were guidelines, all of these countries had guidelines. So the big question is, are they different? Do we get different results? And to my knowledge, the only study that has evaluated this is the study that we published 2 years ago in the Acta Scandinavica. It was a comparison between the FIGO guidelines of 1987, the American College guidelines of 2010, which is the latest guidelines, and the NICE guidelines that were available at the time from 2007. And they used more or less the same data set that's been previously presented. Coming here from the Portugal data set, there were a few more that were included. 151 term pregnancies all more than 37 weeks, or equal, and they were all done within terminal. And come back to why it's so important to do these studies within terminal heart rate, scalp electrode, rather than just including it. So they're all less than 5-minute interval between the end of the tracing and birth. And we asked 27 clinicians to analyze the last 60 minutes, which we sent by email. 9 clinicians from each of these centers. 9 clinicians from the Santa Maria Hospital in Lisbon, where I work now. They were using the FIGO guidelines. They were used to using the guidelines. We asked 9 clinicians from the Beth Israel Deaconess Medical Center in Boston to analyze these 151 tracings using the American College guidelines, and 9 clinicians from St. George's in London using the NICE guidelines. So the same tracing, different criteria, but the criteria that the clinicians were used to using, otherwise it's a little bit artificial. So they were used to using this criteria. So why is it so important to use internal fetal heart rate monitoring? Because we were looking at inter-observer agreement, but also accuracy, sensitivity, and specificity. And we know one of the problems with TTG is signal loss. And we get a lot of signal loss, particularly in the second stage of labour, when the woman is pushing just before delivery. So if we have signal loss, such as in this case, it's actually a case from a hospital in Portugal, and the outcome, you see, there's a stillbirth there. You're really not monitoring anything. It's very difficult to get any information from this sort of signal. And you get much less signal loss when you're using internal monitoring. You get some, but it's really much less than with the external. Another good reason to use internal fetal heart rate monitoring is because you get a lot of contamination from the mother in the second stage particularly. This is an extreme case. It's very pathological tracing. And then all of a sudden it looks like variability is getting better. So actually all of this is the mother until the end. So there's no monitoring for over 20 minutes. And of course, if you have internal monitoring, you don't get contamination from the mother. It's very rare to get contamination. So here, grade 2, hypoxic ischemic encephalopathy and metabolic acidosis, because there's no monitoring of the fetus for 20 minutes, so anything can happen. Sometimes maternal heart rate monitoring is very evident, as we saw before. There are accelerations during contraction and variability changes. Sometimes it's very subtle, and this is a tracing that looks pretty normal, like fetal heart rate is about 120, but then there's this wide gap between two fetal heart rate tracings, which is not physiological, as you know. The fetus doesn't just shoot up like that. And if you get maternal heart rate monitoring at the same time, which many CTG monitors allow, and this is maternal heart rate monitoring, you see that actually all of this part here is the mother and not the fetus. So I think to look at accuracy of CTG, you can. There are two arguments. If you want to know the accuracy, the potential accuracy, you need to have very high quality signal. Then you will know that it will not be used in the proper way by many clinicians in everyday work. And so you will lose some accuracy there. But if you want to get the best accuracy, you need to look at internal fetal heart rate. And I think you need to look at internal fetal heart rate until the very moment of birth or until very close to birth. And to give you an example of that, here you have a normal tracing. Normal variability has got an acceleration, and before it had several accelerations, it just didn't fit in the slide. And sometimes you decide a cesarean section on the patient such as this one because the labour is not progressing or because of some other indication not related to the fetal condition, and you're surprised to see an abnormal outcome because you did not monitor the last moments. And sometimes things change very fast, as Rick was saying yesterday morning. If you did not have this information, how would you predict outcome? And so it's a normal outcome because this normal CTG is always equal to a normal outcome. But if you don't monitor until the very moment of or very close to birth, you can miss out on things that change the situation almost completely. So the outcome here was actually metabolic acidosis in the grade 1 HIE. There was a cesarean section. And obviously cesarean section, you can't do it immediately. It takes 2 or 3 minutes to prepare, so it will take another 3 or 4 minutes before the baby is out. Okay, so things change very fast. And this idea that I think we had in the past, that if you had a normal tracing at the beginning of labor, or admission test, something, I think there's a talk on the admission test later on, that would predict a normal outcome. I think it's completely unrealistic. This labor, there are so many things changing in labor, and the contractions of labor make the condition of the fetus change so fast towards hypoxia and back from hypoxia that you really need to monitor until the end of the delivery, until the delivery. This is just to justify why I think if you look at sensitivity and specificity, you really need to have these optimal conditions to look at the optimal sensitivity. Going back to the study and the 27 clinicians, the 151 same tracing, until very close to delivery. You can see that this is FIGO, ACOG, and NICE. You can see there were more tachycardias with FIGO in 1987. Not surprising because the definition of tachycardia was different in FIGO 1987. It was more than 150 beats per minute, whereas with the other two, it was more than 160. Similar bradycardias, not very often. It wasn't, not very frequent finding. abnormal variability against around 15–20%. Accelerations, there's a big difference between NICE and FIGO NACOG. Actually, the definition of accelerations is almost the same with the FIGO 97 NACOG on NICE. But I think it has to do also with things that are that are inherent to the actual place where we're conducting this study, because St. George's, there's a lot of emphasis, correct me if I'm wrong, Austin, I think it comes back from the days of Ayres, that after a deceleration, a rise in the fetal heart rate is not an acceleration, it's a compensatory mechanism for the previous deceleration. So that should not be judged as an acceleration, whereas in the other two centers, they probably judge these things to be acceleration. Not actually to do with the guidelines, but things that are in the hospital. And you can see this is quite an unselected population. It's not really unselected because they're all internal fetal heart rate monitoring. So why do people monitor with an internal fetal heart rate? Well, either because they have signal loss, particularly when it's a larger laboring woman, but also when you think there's a high-risk situation, such as increased growth restriction, something like that, when you're inducing those cases, but you really want to make sure that you don't have any signal loss. So it is not completely low-risk population, but there was sequential. Every single birth was recorded and in this way, but there must have been some selection of higher-risk cases. But even with some high-risk cases, you can see there are lots of decelerations, whichever classification you need, around 90%, whichever classification you use. How did this translate into the classification? Because all of these three classifications use a three-tier classification system. So it's either normal, suspicious, or pathological in FIGO and in NICE, or in the American classification, it's grade 1, grade 2, and grade 3. See that what's most striking is the American classification, because see, with the American classification, even a relatively low population, you get 82% classified as suspicious, whereas with NICE you get 30-something percent. Big difference. Just like with the American classification, it's almost always suspicious, very few pathological, very few normal. And look at the difference with the NICE. It's all with the English classification. It's almost 30, 30, 30. And with FIGO, you get very few normal. You get quite a few suspicious, but not suspicious in anything else. And the pathological color. So when people say that it's the sensitivity of CTG is high or low, it really depends on the classification system you're using. And that's an important message we get from this study. How does this introduce into inter-observer agreement? We use the proportions of agreement, and you can see there's a very high inter-observer agreement for the American College classification of suspicious, because they're nearly all suspicious. But a lot of disagreement on normal, category 1, and a lot of disagreement on category 2. The overall inter-observer agreement is not high. It's around 50–60%, but it really depends on which classification system you're using. What about accuracy? When we say that accuracy of CTG, when you say that sensitivity of CTG is high, what I think we're really saying is that sensitivity of suspicious and pathological classifications is high. So we're really putting suspicious and pathological together. We're saying that if it's normal, it usually will have a normal outcome, no hypoxia. When it's suspicious and pathological, about 50% have hypoxia, other 50% don't have it. Not necessarily 50%, but around that sort of number. But but it's not really a two-tier system, is it? It's three-tier. So here we looked at the accuracy of the most severe classification, grade 3 for the Americans, pathological for the other two, and how sensitive they were to And you can see sensitivity is high with FIGO and with NICE. But if in the American classification, because you take out all the suspicious, and suspicious are the vast majority, the sensitivity becomes lower. So if you don't include suspicious, you miss many cases of fatal. On the other hand, the sensitivity is very high. When we do grade 3, the baby will use it now. Again, sensitivity of CTG, very high, very low. First guideline probably Professor Mann is taking over as the president of FIGO. So the idea came to revise the FIGO guidelines of 1987 because there are more than 25 years gone since those guidelines, and they're still being used throughout the world, but there was a feeling that they were slightly outdated. So we've got together a group of 50 experts throughout the world. We asked the National Societies of FIGO to appoint subject matter experts, and we looked at the literature to find who were the people publishing in the last 10 years. So we got a group of 50 people together, some of whom are here. So Barry, well, Austin, Tamwaki, Cyril, also with us. So we got these 50 people together, and we decided to do, without any funding at all, to do an email consensus. So it took a long time to prepare. We reviewed the evidence before, it took a long time for the consensus, and it was a 3-round consensus. It was a 3-round consensus. So there's a first version, and there was, I think, 3 weeks to come back with changes and suggestions, and there was a second round, and then there was a third round. By the end of the third round, if people weren't happy with it, they could just say, well, I won't have my name in that particular chapter. But as it happened, everybody had the last be part of the last. So there were 5 chapters. One was just a short introduction on the methodology. There's, I think, a very important chapter, which is the physiology of fetal oxygenation, the main goals of each part of fetal monitoring. I think it's even more important than how to interpret it, because this sets some of the basis of how to deal with some situations in labour. There was a chapter on intermittent auscultation, and we asked the International Confederation of Midwives, which is the equivalent in midwifery to the FIGO. It's a federation of all the national societies of midwifery. They were writing this. They wrote this chapter. And there's a target photography chapter. Here we have 3 authors. I was representing FIGO. Catherine Spong was nominated by the American College of Obstetrics and Gynecology to be a representative in the CTG interpretation, which is the most delicate chapter. And Edwin van der Haren was nominated by the Royal College of Obstetrics and Gynecology to be the RCOG representative. Try to get all the major authors together. And then there was another chapter on conjunctive technologies such as CTG STAN. They are available for download, free download in the International Journal of Gynecology. And we thought at the time it was also important to get together some PowerPoint slides that people could use them locally and to disseminate some of this and organize CTG courses all over the world. So we have examples available to download and people websites in several languages. I've already talked about FIGO guidelines in more detail 2 or 3 years ago, STAN, and just touching on the main differences between the 2015 guidelines and the other guidelines. So we introduced the concept of the average bandwidth amplitude in 1 minute segment. Bandwidth, as you can see, we get with our eye, so it's not a very mathematical concept. Clinically useful, but average bandwidth in 1 minute segments. There was a lot of discussion whether we should be using short-term variability and long-term variability in clinical practice. The idea at the end, the consensus is that we should not have short-term variability because that was too difficult to see with the naked eye. But these are guidelines mainly for reduced variability not only in baseline segments, which is a traditional concept, 15 minutes in baseline within the deceleration. So less than 5 beats per minute within the deceleration. If that lasted for more than 3 minutes, that was to be reduced variability. This was really a fail-safe mechanism because we also have late decelerations that you'll see if they have reduced variability. That's also an alarm sign. But to make sure that it's a bit redundant with the late deceleration definition, just to make sure people didn't miss out on these. But I think with computer analysis we call it short-term variability, reduced short-term variability. We also introduced the concept of increased variability that was not present in the previous FIGO guidelines, wasn't present in the RTOG guidelines, it was present in the American guidelines. So we looked at the literature, found out there were a few cases with where this lasted more than 30 minutes, and this should be also classified as pathological, as I will see if it lasts more than 30 minutes. And I think perhaps the biggest change was the definition of what are variable decelerations and late decelerations. There was a lot of emphasis in the previous literature related to the varying size and the shape and the varying relationship with the contractions, sometimes a little bit late, sometimes coincident. So, but most of the time, I would say most of the time in the majority of labor wards, you don't have a good contraction signal. You have it at the beginning of labor, but unless you have a midwife or a doctor who's there changing, adapting the TOCO, because most places we don't use intrauterine pressure, so we use the TOCO, not dynamometer. Unless there's somebody always readjusting the TOCO, after 1 or 2 hours, you stop seeing the contraction. So, so the idea was to have focus more on the way they looked, on the morphology of the deceleration, the sharp decrease, a sharp increase, and normal variability before and after the deceleration. I think that's a big difference from what was the definition before. We also focused the definition of late decelerations on the morphology, so a slow decrease or a slow increase to the slow return to the baseline, or reduced variability within the deceleration. And because we know that from the animal experiments that were mentioned yesterday, that these are the ones that are more associated with hypoxemia, with the chemoreflex of that in reaction to hypoxemia. And then we summarized everything in one single table, quite an effort, and tried to make it as simple as possible because guidelines are made by experts, but they're not supposed to be used by experts. We know the people who have been working a lot with CTG, they probably have their own ideas, and they're comfortable with some ways. These guidelines were for all the midwives and doctors in the world whose focus was not CTG interpretation. Because, as many of you will know, not everybody who's in the labor ward, not all the people in the labor ward, they are obstetricians. Sometimes they work in gynecology. They are urogynecologists. So their focus of research and of attention is in something completely different. So they just have to be once a week or so in the labor ward. So they're really not too motivated to study this in detail. So we wanted it to be as simple as possible and to be as objective as possible. So normal, we kept the normal suspicious pathological, normal with the definitions that you see there, meaning no hypoxia, no intervention necessary. We knew that there was a big problem with the suspicious because very many different definitions of what was suspicious in the different guidelines. So we just kept it as simple as possible, lacking at least one of these characteristics, but having none of these. So keeping the pathological for the ones that you should have is a high probability of hypoxia. You should act immediately. Suspicious, a low probability of hypoxia. So if you see something that you can revert, that you can correct, then you should act here, not let it go to pathological. But if you don't see anything that you can correct, you can carry on monitoring. And you're pretty safe that the probability of hypoxia is indeed very low. Now, pathological less than 100 beats per minute in the baseline, reduced variability according to the criteria that I said before, increased variability, again according to that criteria, sinusoidal pattern, and we kept what I think are the most frequent events in labour, tried to make them as simple as possible. We just use late and prolonged deceleration, so if it's a variable deceleration, it will always be suspicious, but it will never be pathological. So variables we know are associated with intermittent compression of the cord. So there will be some recovery if the variability is normal. They can go until Christmas, as Austin would say. But if it's the late or prolonged ones that we know may be associated with hypoxia, particularly if they are repetitive in nature. Repetitive means associated with more than 50% of the contraction. And in these, you need immediate action to correct reversible causes, if there are reversible causes. You can confirm with fetal blood sampling or whatever. If you feel you really need to confirm, if this is not possible, then you should expedite delivery. I think there was a big focus on the reversible causes of hypoxia in FIGO. And if nothing else, this will remain from FIGO 2015. I think this is a concept that will linger because CTG has been accused of increasing the intervention rate. And indeed, in the randomized controlled trials of the 1970s and 1980s, it did increase significantly the intervention rate by 66%. But at a time when intervention rate was very low anyway, so I think things may have changed. But we know now that many causes of hypoxia can be reversible. The majority of causes of hypoxia in labor can be reversible because most of the time we have too many uterine contractions, sometimes iatrogenic, so sometimes it's the healthcare professionals who are putting oxytocin to make labor fast. If you reduce it or stop it, or if you give medication that will stop the contractions, we call it acute focolysis. So things like salbutamol, we give it IV. It doesn't really matter what their names are, but there's several medications that change, stop contractions, that we can reverse the progressive hypoxia, and we can actually normalize it sufficiently to avoid a cesarean section or an instrumental vaginal delivery. Supine position, just changing maternal position will correct some of these causes. And sudden hypertension that we get, we don't get it very often nowadays because we have, in some countries, we have a lot of epidurals. And in the beginning of epidural, we used to have a lot of hypertension. Now the anesthesiologists, they usually use a medication that does not give so much hypertension. But now and then we do have hypertension. We don't need to do a cesarean section in these situations. We just give more fluids, and if we need a very rapid response, to give ephedrine. So some of these situations are reversible and do not necessarily need to increase obstetric intervention. Others are irreversible. They actually are less frequent, much less frequent than the reversible ones. Uterine rupture, when the placenta detaches from its uterine implantation site, cord prolapse, and fetal hemorrhage. Fetal hemorrhage is very rare, but it's the cause of hypoxia also. So we also included, for those who did not believe that things can reverse, we included in the PowerPoint, FIGO PowerPoint, a case where you had repetitive decelerations, and then it looked like a prolonged deceleration with maternal heart rate here in blue, and there was salbutamol was given, and you get the contractions that were too many, there were more than 5 in 10 minutes, they stopped for about 10 minutes, and then slowly they came back, and you get a completely normal fetal heart rate at the end here. There's a slight overshoot, and but it normalized after that. And how does FIGO 2015 compare with the previous guidelines. We're using the same data set that we previously described, the 151 tracing, and so we were able to compare it with the results of the others. Gave it to 6 clinicians here in this hospital, and we looked at the incidence of tachycardia, similar to the other ones, to these two. Bradycardia was low. Reduced variability was actually lower, so the definition the incidence made it lower. There were more accelerations. I really don't know why. I think it had to do with the way we here in Portugal we looked at deceleration, which is different from the way we've done in St. George's. And again, a high number of deceleration. Classification, there were more normal classifications with the FIGO 2015, and it's a bit more like the NICE guidelines than any of the others, not the difference that we saw with the American. Is there agreement on baseline evaluation? There was agreement with any of the classifications that we used. Less agreement on tachycardia, a little bit more agreement on bradycardia. Not a big difference in any of these. So quite a good agreement on periodic events, particularly accelerations and decelerations, whichever classification you use. We looked at agreement on classification of decelerations as variable, repetitive, lateral, prolonged. We couldn't do that with the others because they didn't have this definition. But it was actually quite a good inter-observer agreement, at least from moderate to high, with the FIGO 2015, with any of these definitions. An agreement on evaluation of variability similar to the other classifications. Agreement on CTG classification. So there's a higher agreement with FIGO 2015 for the normal category, and similar agreements to the others with suspicious and pathologic. But it does seem that we have more normal tracings with FIGO 2015, and we have a higher agreement on this classification. What about accuracy with FIGO 2015? You can see that for the pathological tracing, you keep a very high sensitivity and a high specificity. But again, 151 tracings is not a lot. It's the number we chose because we thought people were able to look at 150 tracings without going crazy. But the confidence intervals are high, so I think we obviously need more studies to confirm this. Where do we go? Can I just, for 2 minutes on, because otherwise I'm not answering the question. Yeah. So largest consensus reached in the field, you can't really argue against that one. A society representing all obstetrics, obstetricians and gynecologists, and it does seem to lead to increased accuracy, although we need more data on that. It's been endorsed by the two leading two only European associations in obstetrics and gynecology and perinatal medicine, also by the Asian and Oceania Federation of Obstetrics and Gynecology, and also by the two Latin American associations. What's happened with the American associations? So both the Society of Maternal Fetal Medicine and the American College were heavily involved in the development of the guidelines. The American College did not endorse, but supported the FIGO guidelines and has not changed their guidelines since then. We could not get endorsement from the Society of Maternal Fetal Medicine, I think for political reasons, and I really couldn't figure out why we couldn't get the support from them. What happened in England? Well, there was, Austin will probably know this better than I do, but there was some use of the FIGO guidelines. There was quite a few hospitals who wanted to use the FIGO guidelines and started using the FIGO guidelines, and then NICE guidelines of 2014 had been published, and after 1 or 2 years decided to revise the NICE guidelines and to use many of the concepts that we have in FIGO. So it didn't just endorse or adopt FIGO, but it changed many of the things that we use. Two interesting situations in Sweden. They were endorsed as they are because I think, again, for political reasons, there's a lot of disagreement in Sweden between those who use STAN and those who did not use STAN. And the society was at the time dominated by people who didn't like STAN, and there's quite a lot of, aggressiveness between the two. So they decided to use FIGO because FIGO is completely different from STAN. It's difficult to be compatible with STAN, so I think they endorsed it just to annoy the other group. Norwegian society, we had a strong representative, strong in many ways, involved in the FIGO guidelines, but she was very much against the fact that we changed our criteria for tachycardia from 150 to 160. So she ended up actually accepting to be part of the FIGO guidelines, but she was strongly against it. So as she's a very strong person in Norway, the Norwegians have not accepted the FIGO guidelines because of that. So this is a friend of Austin. Austin will tell you.
You didn't say the name, right?
No, I didn't. No, I didn't. But Austin knows her well. Yeah. What about STAN? Sorry, just to answer the question on STAN. So for Oberoni. So STAN were discussing for a very long time whether they should adopt the FIGO guidelines or not. STAN guidelines were developed basically by one person who developed the whole technology, but they've been pushing the idea that it's a modification it's a modified version of the FIGO 1987 classification, which obviously it is, because everything can be modified, and they modified it enormously. They included another category, so it's modified, yes, but I think it has very little to do with the FIGO 1987. So after a lot of discussion, and I think mainly based on the idea that they'd done 7 studies and invested a lot of money in some of the randomized control trials using the previous classification, they decided not to change the STAN classification and maintain it as the original. And the rationale was that the new FIGO system only uses 3. Well, the old system also uses 3, but it was in contrast with the STAN guidelines. And also there are individual. It's not just the societies who have their classifications. Also, they're also in certain hospitals and groups of individuals. There are also different classifications. This one, I think, this one comes from Austin's hospital. It's been promoted. It's the rationale. It's developed by the editorial board of the guidelines, based on the experience gained from maternity units I think in UK, basically in the London area, that have managed to reduce emergency cesarean section. So it's another approach, I think, very much individual based, but I think we cannot avoid, obviously, individuals having, or groups of individuals having their own ideas and promoting them. Just to finish off, I think whether countries or hospitals or individuals, whether they endorse or they do not endorse the FIGO guidelines, it doesn't really make any difference, because I think what's really important is some of the messages contained in this group of 50 people who got together and came up with this consensus. They've been mingling, they've been part of the other guidelines, even if the national societies or the individuals did not use them in their face values, but they've been incorporating many of the concepts, and that's what we really want. We want to have concepts that will actually lead to better outcomes for mothers and babies. Thank you.
If we want to have meaningful discussion and there's another talk that I should think, I think we are going to run well in fact. I'm fine with that. I'm very interested. This is what I'm interested in. I needed to make a choice as a chair, right? Whether I'm strict or no. We started late, he was running over late. I know the next speaker is going into also something about that. I think we're going to run into that. But then we also have a busy afternoon, so ask you to bear with us. It is obviously very busy. And then when we go for dinner class, so I would allow questions.
Again, a very, very naive question, so no bad intention. Okay. Since you came up with super clear definitions like between this and that, thresholds, values, since you have a very good inter-observer agreement, why is it that computer is not going to compute this very efficiently with 100% agreement on the rule?
No, I agree, and that's we came up with Neж was presenting some of the SysPort of 4.0, which is the version that's been adapted to the guidelines, and she's busy
testing the accuracy of that in the larger data set, because we thought the 150 cases are interesting for this, but we need a larger data set with more cases of metabolic acidosis. So I will have to wait for the results of the initial study, but I think it really should compute just as well.
Question, yeah. Doesn't the availability of computer-based AI eliminate the precaution about making the printed guidelines that they can read simple? You can now hide complexity in the AI, and they don't have to know or interpret the individual patterns.
Well, it probably holds true for many high-resource countries, but we know the world is not just high-resource countries, not just people who have this access to this. But I would agree that, in high-resource countries, we are definitely going in that direction with the alerts. But I think, again, it's a medical legal, that's your area, Barry, but it's a medical legal problem, because I don't know of any software company, any company that will actually accept to have the responsibility for telling clinicians what to do. So it will be ultimately, in my view, at least for the next 50 or 100 years,
foreseeable future.
For the foreseeable future, it will be the clinicians taking the decisions and having the responsibility for those decisions. And actually, all these systems that Dinesh was talking this morning that have become alarm systems, even the infant system has become an alarm rather than telling people what to do, rather than being a decision support system. It's become an alarm. So, from a medical legal point of view,
that's why training is so important. Someone asked me the other question about training, giving them a learning system, but
You're going to give me mine?
Yeah. Sure.
I've got one. I thought early in your talk, we were talking about predicting good outcome or predicting bad outcome, looking at the admission trace or any other part of the trace earlier on. And I just wanted to make a comment and a question and a thought that when we talk about predicting outcome, certainly with algorithms, we certainly talk about risk assessment. You cannot predict the future. You cannot give a certainty of 100%. But if you admit a patient, so am I correct? That if you admit a patient who has no history of any adverse outcome, second pregnancy, normal birth the first time round, let's say, no indications for anything, you put her on admission trace, the trace is normal, is it correct to say that you have a high probability, very high probability, that she's going to have a normal labor and normal delivery? However, of course, something might go wrong in that particular pregnancy.
So this is
but the probability is high.
Forward.
So we don't talk about prediction, we talk about probabilities.
Yeah, I take your point. When I'm talking about prediction, it is about the last minutes of the recording just before birth, being able to predict, maybe it's not the right word in English, but being able to, any word I can find is predicting the outcome. Yeah? So, well, here we're talking about validity studies, so we're talking about sensitivity and specificity. So that's what I meant when predicting. I wasn't talking from a clinical point of view. I think from a clinical point of view, if you have a normal tracing, a normal pregnancy, and a normal tracing at the beginning of labor, there's obviously a high probability that you have normal outcome. Yeah, but if you look at abnormal outcomes, if you look at, for instance, there's a Norwegian data set of cases that went on to have medical legal cases and because of hypoxia. More than 50%, or about 50%, come from low risk situations with a normal CTG.
That's true about NICU admissions
too. True about that. But the vast majority do well, but the ones who do not do well, they come from high risk as well as low risk.
Well, but those are risk assessments of the mother rather than specifically of